Tuberculosis is an infectious disease that primarily targets the lungs, but it doesn't always stop there. It can spread to the kidneys, the bones, the meninges, even the lymph nodes. The culprit is Mycobacterium tuberculosis, an acid-fast rod that grows slowly, survives in the body for years, and thrives in conditions where poverty, malnutrition, and overcrowding are common. It's a worldwide public health challenge, and despite decades of treatment, TB remains the leading infectious cause of death globally. In the United States, TB isn't as common as it once was, but it hasn't gone away. We still see thousands of cases every year, many linked to immigration from high-prevalence countries, crowded living conditions, or gaps in healthcare. Transmission happens through the air. A person with active TB coughs, sneezes, laughs, or even sings, and tiny particles, so small they can float in the air for hours, are released. When someone nearby inhales those droplets, the bacteria travel deep into the alveoli. From there, the pathophysiology unfolds. The bacilli settle into the lungs, multiply, and spread via the bloodstream or lymph system to other organs. The immune system responds with an inflammatory reaction. White cells surround the bacteria, trying to wall them off. This leads to granuloma formation, with a classic feature called the gone tubercle. Inside that tubercle, tissue dies and forms a cheesy caseous mass. Over time, it may calcify and scar, trapping the bacteria in a dormant state. But those bacilli don't disappear. They can reactivate years later, especially if the person's immune defenses weaken. That's why we talk about primary infection, latent TB, and reactivation or adult-type TB. Risk factors are important to remember. Anyone in close contact with an active case is at risk. So are people with compromised immunity, patients with HIV, cancer, or transplants, or those on long-term steroids. Substance use, inadequate housing, homelessness, and malnutrition all increase risk. Certain medical conditions like diabetes or chronic kidney disease make patients more susceptible. And healthcare workers aren't exempt. Exposure during procedures like bronchoscopy, suctioning, or intubation can put them at high risk. The signs and symptoms of TB usually creep up slowly. Patients may have a low-grade fever, a persistent cough, night sweats, fatigue, and unintentional weight loss. The cough can start off dry but often becomes productive with mucopurulent sputum. Hemoptysis, coughing up blood, may occur. In older adults, the presentation can be subtle, sometimes just a change in behavior or mental status, along with poor appetite and weight loss. About 20% of cases involve extrapulmonary TB, and in patients with HIV, it's even more common. Diagnosis involves several steps. We start with a thorough history and physical exam, and then we use specific tests. The tuberculin skin test, or Mantoux test, is a classic tool. A small amount of purified protein derivative is injected intradermally, creating a raised wheal. After 48 to 72 hours, the site is checked for induration, not redness. An induration of 5 millimeters may be significant in high-risk groups like HIV-positive patients or close contacts of active cases. 10 millimeters or more is usually significant for most people. But the test isn't perfect. People who are immunosuppressed may not mount a reaction, which is called anergy. Because of these limitations, we also rely on blood tests known as interferon gamma release assays. The QuantiFERON TB Gold Plus and the T-Spot are both widely used, especially for patients who have had the BCG vaccine, since that vaccine can cause a false positive skin test. These blood tests give results in about a day. A positive result means TB exposure has occurred, but more testing is needed to determine if the disease is active. Sputum cultures remain the gold standard for diagnosis because they confirm the presence of M. tuberculosis. Smears may show acid-fast bacilli, but cultures are necessary for confirmation and for testing drug resistance. Every isolate is checked for resistance, and this testing is repeated if patients don't respond to therapy. Older adults can present special challenges. Their symptoms may be vague, and their skin test may not react at all or may react only after a delayed second test. This is why careful screening in long-term care facilities is so critical. Treatment of TB isn't quick. It requires at least 6 months of therapy, often longer. The challenge is that M. tuberculosis grows slowly, and if therapy is stopped too soon, the bacteria persist and relapse occurs. Even more concerning is drug resistance. We see multi-drug resistant TB, which is resistant to both isoniazid and rifampin, and extensively drug-resistant TB, which adds resistance to fluoroquinolones and injectable second-line agents. These forms are much harder to treat and are more common in immunocompromised patients, particularly those with HIV. The first-line medications you need to know are isoniazid, rifampin, pyrazinamide, and ethambutol. They are usually given together in a 4-drug regimen during the initial phase of therapy, which lasts about 8 weeks. After that, patients move into a continuation phase with fewer drugs, typically isoniazid and rifampin, for 4 to 7 more months. Patients are generally considered non-infectious after 2 to 3 weeks of continuous therapy, but completion of therapy is judged by the number of doses taken, not just the passage of time. Nursing management plays a huge role in outcomes. Promoting airway clearance is essential, since secretions can block the airways and worsen gas exchange. Hydration, postural drainage, and proper positioning help with secretion clearance. Adherence to the treatment regimen is one of the biggest challenges. The drug schedule is long and complex, and side effects can discourage patients from continuing. Nurses educate patients about the importance of sticking with therapy, explain side effects, and stress that completing treatment not only cures the patient, but also prevents transmission to others. Patients taking isoniazid should avoid alcohol and certain foods like aged cheese, red wine, or tuna, which can cause dangerous reactions. Rifampin may discolor body fluids and can interfere with many common medications, including oral contraceptives and anticoagulants. Monitoring for hepatitis, vision changes, and other side effects is essential. For patients at high risk of non-adherence, directly observed therapy, where a healthcare provider watches the patient take each dose, has been shown to improve success rates, though it requires resources and coordination. Nutrition and activity also need attention. Many patients are weakened by the disease, with anorexia and weight loss. Nurses can support small, frequent meals, nutritional supplements, and connect patients with community resources like meal programs. Activity is introduced progressively, building endurance as patients recover. Preventing transmission is the final pillar of nursing care. Patients must learn to cover their mouth and nose when coughing or sneezing, dispose of tissues properly, and practice good hand hygiene. TB is a reportable disease, so health departments get involved to ensure contact tracing and screening. One last complication to note is miliary TB. This is a rare but serious form where the bacteria spread through the bloodstream, causing tiny nodules throughout multiple organs. It can present suddenly with high fever and rapid progression, or more slowly with anemia and debility. The chest X-ray shows tiny millet seed-like densities scattered through the lungs. Treatment is the same as pulmonary TB, but these patients require close monitoring because of the systemic involvement. The key takeaway is that TB is still with us, still dangerous, and still demanding careful, coordinated care. Nurses are central in diagnosis, education, adherence, and prevention, making the difference not only for the patient in front of us, but for the public health of entire communities.